Okay. Thank you, everybody, for your attention. We hope you enjoyed lunch. And this next speaker, it gives me great pleasure to introduce Dr. Sylvia Richey, who's our Chief Medical Officer at West Cancer Center and Research Institute. And she will be talking about future challenges and opportunities in community oncology. Thank you, Sylvia.
Okay, good afternoon, everyone. Welcome to Memphis. For those of you that are not here, we're so happy to have you at this conference. It's really been interesting hearing the talks of this morning, and when I looked at this topic, I thought, gosh, you know, we're talking about the future. I'm supposed to be looking into a crystal ball and trying to figure out what the answer to that question is. And I thought about when I was a fellow, back in 2000, it was November of 2000 to be specific. I don't need anyone doing math, don't worry about that. But I saw this patient. She was a 42-year-old African-American female, and she was diagnosed with CML. And I worked my damnedest to get her on this trial of STK571. And the trial closed in October of that year. So unfortunately for her CML, she had to get a bone marrow transplant and wound up dying of complications. In May of 2001, Gleevec was approved. That's how close she was. That is how close, and I think of her to this day about opportunities that were missed, right? And so, but look at that back then. We were like, hey, this is a target. Maybe we'll find some more of those. My God, look at what's happened and where we are. So let's talk about challenges first, because everyone always says, you know, end on a positive note, that kind of thing. So we'll talk about challenges. And really, what are our challenges? It's alphabet soup. Our challenges are not necessarily things for our patients. It's outside influences on how we're actually going to practice medicine as a community oncologist. We have CMS coming at us from one direction, the new EOM from another. PBMs are always out there, and we're trying to, you know, figure out what their actual role is, and then value-based care, and of course, cost. So let's look at each of those. So CMS is Center for Medicare and Medicaid Services, and that's who is always dictating our fee schedules, right? And that's what other private payers follow along and kind of guides the rest of the payer. And so we're really at their mercy and don't get a lot of input about how things should go. And it's not until all of a sudden we hear at the beginning of the year, this is gonna happen, then by the end of the year, we're lobbying to our congressmen and our senators and hoping and praying that something doesn't change. So that's a constant battle that we're fighting. Then, of course, we have cost. It's the cost of a lot of things. It's the cost of drugs. It's the cost of supplies. If you think about it, our CEO, Mitch Graves, he always says, you know, we're in Memphis, let's use FedEx as an example. When the prices of gas go up, FedEx cost of operations go up. So guess what? It costs you more to mail that same package, right? But in medicine, we don't have that downstream person to put that increased cost to, right? So our fee schedule has already been dictated by our payers. It's not as though we can say, hey, our cost of supplies have gone up, and so now we need you to pay us X more dollars. It just doesn't work that way. The cost of the workforce has gone up. Look at what's happening in the nursing crisis due to COVID. Physicians are getting burned out, you know, and that's something that we really just have to take into consideration. It's costing more to hire the same workforce back. Cost to patients, co-pays, high deductible insurance plans. I mean, it's getting more and more difficult for patients to even be able to afford the treatments that we are recommending that are going to be great for them to take and really help them. And then ultimately, that increasing cost leads to the community oncology practice decreasing margins. And so we've got to try to keep our door open, right? If we can't keep our door open, who's going to take care of 80% of cancer patients in the United States? So all of this works together when we're talking about how this is affecting community oncology and what the challenges are. All right, PBMs, pharmacy benefit, and I put in quote, managers. And PBMs really are the middleman that are negotiating on behalf of payers with the supply chain to dictate prices. PBMs are able to charge these DIR fees. DIR fees are these kind of clawback fees that stands for direct and indirect remuneration. That happens 6 to 12 months after you've already prescribed a medication for a patient and you've been paid by the payer for the patient. Then we all of a sudden get an invoice for these DIR fees that are based evidently on some type of quality metric that we are unaware of. And it's kind of this black box and keeps everything secret, but I found out that actually what these quality metrics are have nothing to do with medical oncology. So if I am prescribing an oncologic agent, and this is talking about oral oncologic agents. If I'm prescribing an oral oncologic agent to a patient, then what happens is I prescribe it, but then later, 6 months later, I get this DIR fee on that same prescription because that patient was diabetic and is not on a statin that I have nothing to do with, right? So it's just kind of this black box, and it gets really frustrating. So how do we manage that? That's a challenge that we've got to address in the future. Value-based care, it can be a challenge, and it can be a challenge if you're not prepared for it and don't know how to set your system up in order to make that something that could potentially be profitable. We're moving to value-based care. Everyone has their own different model of it, but obviously the Enhancing Oncology model is CMS's, and it's coming July 1st. Obtaining and retaining talent. We want the best oncologists. We need more oncologists. We want the best ones. We want the best nurses. We want the best advanced practice providers in order to take care of our patients. But burnout after COVID has been really difficult, and so this continual workforce has been a continual problem and challenge. And in general, the complexity of running a community oncology practice is just greater than it ever has been before. Let's look at our opportunities. Oh my gosh, I thought value-based care was on the challenge. It can be a very big opportunity, and if you're prepared for it and organized appropriately and taking care of patients in the way that it really should be, then you'll probably do just fine. It's those target prices that are the moving target that we really have to be aware of. Patient communication. Thank God for Zoom. Like, it's been a game changer, right? Look at telemedicine. We use Doxy.me for our platform, but it's been unbelievable what we can do. It's just so nice to be able to communicate with the patients and not have them come back in the office for a result, or just being able to check in quickly. Hey, I want to check on you next week and let's see how you're doing. I mean, it's just been really so nice to be able to do that, and fortunately we're going to be able to continue that. Remote patient monitoring, for those of you that aren't aware of that, this is a whole nother sort of revenue stream, if you will. And you have to have a device that measures a physiologic measurement that then gets, the information comes back to you at the practice, and you're able to kind of keep an eye on your patient from afar. And if you see changes, then guess what? You can reach out and make those appropriate changes. So there's going to be a lot about remote patient monitoring. Obviously, we've got improved, personalized, precision, targeted medicine, whatever you want to call it, with our testing and our therapies. We've got a booming oncology drug pipeline, and the genomics of a tumor now are what are dictating the treatment. Technology, AI, decision support tools, not only in our treatment therapies, but it helps us find the patient that may be in trouble down the road. Who do we need to keep a closer eye on? Who is more likely to get rehospitalized? Those types of things. And so that is really important information when you're in a value-based plan and you need to know how to keep that patient out of the hospital. increasing cell and gene therapy approvals. I mean, we sat here and listened, to our myeloma and sarcoma talks, and it's amazing, but it's expected that there'll be over 20 by 2025, which somehow it's February of 23 already, and that's really not that far away. So this is just such an exciting time. And then what's another opportunity? To decrease that disparity gap, not only with access to care, but access to technology. It turns out that those two go hand in hand, and we need to figure out how to be able to access, make sure that there's no disparity gap when it comes to technology. And then when Dr. O'Day was speaking, I thought, I left something off the list. That's another opportunity. And another opportunity really is that real world data that we have in community oncology. We are lucky enough to be the ones that have all that information. You saw from her data how powerful it really is, and so we need to be able to leverage that as well. So we've got a lot of opportunities as well. When Dr. Summer asked me to give this talk, I kind of went through and thought about these things. Then after I finished, I thought, I wonder if I'm on point. So I decided to ask ChatGPT. It was fascinating. So I literally typed in the question, what are the challenges and opportunities in community oncology in the future? And this is the list. And it's actually pretty close. And so I'm not sure if that validates me or AI, but it was really pretty interesting. But you can see cancer diagnosis and treatment complexity, increasing cost of care, shortage of oncologists, disparities, integration of new technologies into clinical practice. And we're always, fighting with our EMRs and get me that molecular data in the right field so I can run my reports and know how to do some more research. Opportunities, advancement of precision medicine, development of new cancer therapies, increased focus on patient-centered care, expansion of telemedicine, remote patient monitoring, and growth of personalized and immune-based treatment. Then ChatGPT even summarized it. And I want to read this word for word so I don't mess it up, because you can appreciate how bogus, if you will, it is. Overall, the future of oncology care requires innovative solutions to overcome existing challenges while taking advantage of new opportunities to provide better care to patients with cancer. Duh. I don't think I could have said it better myself, but I will say this. I think the future is bright, and we need to keep pressing forward. And if the next 20 years are as amazing as these last 20 years, then I feel blessed. Thank you.